job at Freeman. Oh, I will just get rid of this. Got it. Can you see I've got a big notification in the middle of my screen? Is that on yours as well? No, fine. Then I'll just carry on. Hang on. Why is that there? Got it. Ah, there we go. Okay. So this title is from a project that I conducted during my year at the Freeman. And it's an area that I'm particularly interested in, both in terms of identification of liver disease, but also in terms of the management and prevention of alcohol-related liver disease. So the title being, does fibrosis assessment among patients with alcohol dependency identify cirrhosis, promote abstinence, or reduce alcohol-related admissions? So just a little bit of background, as you may or may not already be aware, there are several stages of liver fibrosis, and this diagram represents that spectrum where healthy liver becomes inflamed, often due to the accumulation of fatty tissue, which can be driven by multiple causes, including alcohol, among others. That leads to a hepatitis, describing inflammation. That can lead to fibrosis, describing scarring, and then subsequently further scarring, leading to cirrhosis. And this is, as I say, a spectrum, and it's possible to move from one stage of the spectrum to another at most stages until you're getting towards the sort of cirrhosis end of the spectrum, where it's a bit more difficult to achieve reversibility at that stage. The problem with fibrosis in a lot of ways is the fact that there are no symptoms, and it's difficult to identify which of these patients, or how do we diagnose these patients earlier in that spectrum of disease to prevent the development of irreversible cirrhosis. With that in mind, alcohol being a major risk factor for fibrosis sort of led to the title of the project. How do we assess for liver fibrosis? So there are both non-invasive and invasive methods for doing this. Non-invasive tests include things like blood-based test calculations, Fibroscan, and in some centres we can use MRI. And the invasive methods include liver biopsy. Clearly, that's reserved for slightly more challenging cases in terms of the underlying cause, and we don't go around liver biopsying everybody. With regards to Fibroscan, because that's relevant to this project, this is a non-invasive test which delivers high frequency sort of sound waves through the liver, which generate a liver stiffness measurement in a unit of kilopascals. The higher the liver stiffness, the higher severity of the underlying liver fibrosis. And internationally, it's recognised that a Fibroscan liver stiffness measurement of about 8 or less excludes clinically significant fibrosis. So 8 or less, no concerns, and greater than 8, there are different parameters about how you might manage or survey those patients, and I'll come to those in my methods. And the images, as you see here, are those of a Fibroscan and what's involved. So now we're getting on to the meat of the background for this project. So why is the question worth asking? Why is it worth identifying fibrosis in those with alcohol dependency? Well, firstly, mortality from alcohol-related liver disease is the leading cause of liver-related deaths in the UK, and mortality continues to rise. And we've seen a trend in a rise of alcohol-related liver disease deaths over the last 20 years. And it's a trend that continues to rise, which is in contrast to all other causes of major diseases, including things like cancer and cardiovascular disease. Cost. So the cost of alcohol misuse to society is estimated to be in the several billions. And the indirect costs of alcohol on society are probably far greater than that through unemployment or other harms from injuries. And in addition, we think about the pattern of the interactions of patients who perhaps drink alcohol excessively. Those are also quite costly. So they're often repeated admissions relating to alcohol use, but also in the patients whereby cirrhosis hasn't been identified until it's too late, those admissions with advanced liver disease are far more costly and lengthy than perhaps picking up these patients earlier and intervening sooner. So any intervention that allows for that would seem worthwhile, and we wanted to explore that. Alcohol consumption. So again, over the last 10 or 20 years, our pattern of alcohol consumption in the UK has changed. We've gone from drinking lower volume strength beers and ciders in public establishments with defined cut-off periods by close time to drinking higher strength volume of spirits and wines at home. And that's an effect that's only really been compounded by the COVID pandemic. So our alcohol consumption is rising or has risen. Awareness or a lack of awareness among the general public about what constitutes harmful alcohol intake and also the associated risks, but also a lack of awareness among healthcare professionals about what constitutes harmful drinking, how to screen patients appropriately, and where to refer those who are drinking harmfully. And stigma. I think it goes without saying that alcohol-related disorders are highly stigmatized, as is liver disease in some areas. And so increasing people's knowledge often comes with a reduction in stigma. And so we felt that this project may contribute to that as well. And I'll just move my box here. And finally, this sort of fibrosis assessment among those who drink alcohol harmfully, which in men is deemed as 50 units, more than 50 units a week, and in women greater than 35 units a week. Both British guidelines and European guidelines suggest that we should be offering these patients a fibrosis assessment. So this work is in line with that. So I will just... yeah. Okay. So what was the aim of this project? Sorry, I'm just trying to move my cursor. At the moment, I've got my own face in the middle of my slide. Sorry. There's the mouse. There we go. So the aim of this project was to invite a minimum of 35% of patients presenting to the trust with alcohol dependency for a fibrosis assessment. We wanted to assess the uptake of that among that population and the prevalence of clinically significant fibrosis among that group. So all admissions to Newcastle Hospital's NHS Foundation Trust were reviewed prospectively over a 1-year period, spanning from April 2022 to March 23. And we included adult patients who were admitted for 1 night or more with alcohol dependency, coded for as either their primary or secondary diagnosis. We invited all of them to attend Fibroscan, and we also recorded, or we listed their self-reported alcohol consumption. We excluded any patients who we knew already had cirrhosis and were under liver services, or those who had had a liver stiffness measurement from Fibroscan within the previous 12 months. Or in patients who had a life-limiting comorbidity, we also excluded those, and anyone who lived out of area. So this table delineates how we interpreted the Fibroscan liver stiffness measurements. So as I mentioned earlier, a score of less than 8 was felt to have excluded clinically significant fibrosis, but those patients were still written to with lifestyle advice about the fact that their alcohol intake was harmful and they should consider or seek advice about reducing that. Those with a liver stiffness measurement of 8 to 11.4 were deemed to have probable moderate fibrosis, and again were offered lifestyle advice and a 2-year interval Fibroscan. Those who had a liver stiffness measurement of 11.5 to 14.9 were considered to have probable advanced fibrosis and were invited to attend hepatology clinic. And those who had a liver stiffness measurement greater than 15 were deemed to have probable cirrhosis and again were invited to attend a face-to-face hepatology clinic appointment. So in terms of identifying those with clinically significant fibrosis, essentially we were looking at all those who had a Fibroscan of greater than 8. So during that 1-year time period, there were 981 admissions among a total of 696 patients. So that mismatch representing those who repeatedly attend. 100 patients with cirrhosis were excluded. And 54% of those admissions were invited for TE is transient elastography, which is Fibroscan. So we met that minimum target of 35%. 49% of those who were invited actually came to their Fibroscan appointment. And among those who attended, 64% were male with a median age of 50 years and a median weekly alcohol consumption of 140 units. The median liver stiffness measurement was 5.4 kilopascals. So, you know, by and large, the majority of these patients actually had normal Fibroscan readings. So of those who attended the Fibroscan, 81% had a liver stiffness measurement of less than 8. So clinically significant fibrosis here in that group excluded, provided with lifestyle advice. There 11% were offered a 2-year interval Fibroscan with a possible clinically significant fibrosis, liver stiffness measurement. 3% had a liver stiffness measurement of the 11.5 to 14.9 and were invited to clinic. And 6% had a liver stiffness measurement greater than 15 and again were invited to clinic. 79% of those who attended clinic or who were invited to clinic attended. And at those clinic appointments, 55% of those reported that they had achieved abstinence from alcohol. And a further 27% reported a reduction or significant reduction in their alcohol intake. So we wanted to look at that group again with clinically significant fibrosis, so liver stiffness measurement of greater than 8, as to how that might have impacted upon their alcohol-related presentations to hospital. So I looked further at in the group who had a liver stiffness measurement of 8 to 14.9, there was a 36% reduction in their attendances to hospital for alcohol-related reasons in the 6 months before compared to the 6 months after Fibroscan. And in that same effect was seen, but to a greater degree, in those who had a liver stiffness measurement of greater than 15, where we were deeming those patients to have probable cirrhosis. So I think in answer to that question, does fibrosis assessment among these patients identify cirrhosis, promote abstinence, or reduce alcohol-related admissions? That the answer is yes. So half of those that were offered it attended their Fibroscan appointment. Clinically significant fibrosis overall was detected in 20% of the cohort. Advanced fibrosis and cirrhosis was detected in 6%. And in those that had advanced fibrosis or cirrhosis, we observed a reduction in alcohol consumption, as well as a reduction in alcohol-related presentations to A&E. Limitations. So what is the longevity of that effect? So yes, we saw a reduction in presentations to hospital. Yes, we saw a reduction in their alcohol intake, but we were only looking at the sort of 6-month period following that initial Fibroscan, and how long will that effect last? Having just had provision of information, it's fresh in the mind, and perhaps motivation is higher. And, you know, I haven't looked further as to whether that effect wears off. The attendance rate to Fibroscan invitation was only 50%. Is that a good enough attendance rate for a healthcare intervention? I would argue that yes, it is, among a population who are otherwise perhaps typically much harder to reach with traditional methods, and we're capturing them at an acute phase through A&E. Clearly, offering somebody a Fibroscan and advising them about their alcohol intake doesn't address the mental health issues, which often are hand in hand with dependency issues, including that relating to alcohol. And what about those who had a liver stiffness measurement of less than 8, but were sometimes drinking upwards of 50, 60 units of alcohol a week? Are we providing that group with false reassurance that, you know, their liver's fine, so carry on? So to summarize, I think mortality from alcohol-related liver disease is unacceptably high, but actually entirely preventable. It's also a condition of inequality, and both of those issues, I think, warrant urgent attention really from the healthcare profession as a whole and society. It would seem that this sort of proactive invitation to a liver fibrosis assessment has promoted behaviour change. It's provided an opportunity for education and appears to have reduced alcohol intake and promoted abstinence. I think with an increase in knowledge around a topic comes a reduction in stigma. And I think it would be reasonable to assume that if this sort of project or intervention could be maintained, it would lead to a mortality benefit in this group. And finally, this exact method is entirely in line with British and European guidelines. So to my mind, it would seem an intervention worth continuing with. These are my acknowledgements. Some of you may know Lorraine, one of the specialist nurses at the Freeman, along with Professor McPherson and Dr. Masson, 2 of the consultants in the liver unit who helped me with the methodology of this project. So thank you very much for your attention. I'd be happy to take any questions from anybody.
That was excellent, Rachel. Very good. I've got a couple of questions, but we'll before anybody else. So if anybody has a question, please put your hand up, either your virtual hand or your real hand. That's the one on the end of your arm, and I'll put them in. Hopefully, do it in order. The first question is: did you look at the clinic that used to do brief intervention with Chris Day and a nurse called Linda Flint, and it was absolutely brilliant. And the number of people who were cured from alcoholism, if you like, during the time that ran. But they had to bring the patients had to bring a diary with them, and they had to come back every week, and they got a reminder if they hadn't attended, you know. And that was absolutely brilliant. But they run out of funding. But I mean, that was a great way of doing it, but it's kind of labor intensive. I don't know if you knew about that.
I didn't know about that. The way that we initially offered these Fibroscan appointments was with a set appointment time. And we realised quite quickly that that didn't work for a lot of these people who perhaps have, you know, a lot going on, and they couldn't make it to set appointment times. So we then switched to doing sort of blocks of Fibroscan, walk-in Fibroscan clinics, which allowed people to turn up at their own convenience, really, on any set given day. And we found that that meant that people did, people were more likely to come if you just did it on an open day. But the problem with that is that it did become a bit labour intensive because you had to repeatedly remind people of which days we were doing Fibroscan clinics and things.
Yeah.
And also it required quite a lot of time going through all of the presentations to ED and picking out the correct coding for patients who'd come with alcohol-related presentations. So yeah, I mean it is tricky. It's we need manpower or
Yeah,
women
absolutely. Well,
behind the scenes.
we've got a leaflet that was written by Stuart Macpherson called "Looking After Your Liver," and we've actually sent out this year 1,000 already. Just this year. So actually,
Yeah.
since April this year, there's 1,000 out, and it tells you that you can reverse fibrosis if change your drinking habits, and or if you do drinking and you stop drinking, it can do, and exercise and all of the things that can help.
I think I think I might even have pinched one of those leaflets and brought it back to
Yeah.
London with me.
Oh, well, that's good.
Yeah.
That's good. It's very, very popular. But I think I've just been asked for another 500 for the clinic, so they may be going to give them out to people who come to clinic. I'm surprised it was 981 people turned up. It's quite a lot, isn't it?
Yeah, I mean, and I think what I found quite interesting among that number is that that was only 696 patients or whatever it
Yeah,
was.
yeah,
So it just shows how if we can break the cycle of the repeated admissions to A&E because of alcohol or other drugs,
yeah,
that's a huge cost saving if we
yeah.
look at it in terms of cost, not only
Absolutely.
the benefit for the patient, but it saves those costly repeated presentations.
Yeah. Well, we've been to A&E and seen what's happening. I mean, a percentage of the people there are on drugs as well as alcohol. And that's where you're blurring the line again. I mean, they're walking about in a trance until somebody helps them. Anyway,
Mm.
I've got a question from Yvonne. You're muted, Yvonne. Very
Yeah, thanks, John. Thanks very much, Rachel. It's just a quickie on the back of that in terms of I wasn't sure how, perhaps I didn't pick it up. Forgive me, Rachel. I didn't pick it up. So this was purely and simply they were approached via A&E. Is that right? It wasn't through any of the clinics.
No,
Is that right?
yeah, just
Right,
any. I think
right.
we were trying to capture people that we otherwise wouldn't capture.
Okay.
Um,
So yeah, right.
so it might be people who, I mean, for example, people who are perhaps coming from, I don't know, they've got sort of gastritis, stomach issues from excess alcohol, or they've come in vomiting blood, or, something where they've come into contact with A&E because of excess alcohol, which those patients that they come to A&E a lot, but A&E are not medics, they're not hepatologists, and aren't necessarily going to be thinking about how to assess this patient for fibrosis, because that's not
Yeah.
their job.
Yeah, no,
But
that was what I was going to say. How would you in A&E, how would you differentiate? So someone was coming in with had alcohol problems, but they were going in, they were just being treated for, say, for instance, a head injury or something like that. So how were they approached, Rachel, in terms of, well, we think you could actually benefit from receiving a Fibroscan, or a fibrosis assessment? I just wondered.
yeah, so yeah, that's the $1 million question, I think.
Okay.
It's very difficult because everybody's risk factors are so different, and there isn't a one-off test that will tell you in the A&E department whether someone's got advanced fibrosis, and that's part of the problem with it. If I had my way, who would I send? Probably probably this exact group, the ones who repeatedly attend, that are drinking greater than 35 units for women, 50 units for men, or yeah, I think it's very hard. It's really, really difficult to narrow down an appropriate screening tool. This was a blanket approach. Anyone essentially who's dependent on alcohol in any way would get an invite to Fibroscan. But as you saw, by and large, the majority of those people do not have any clinically significant liver disease. So it's really tricky. Stuart McPherson is very heavily involved with screening tools in primary care, and how best to identify patients in GP land, as we say, and alcohol misuse and things come into that. Haven't really answered your question, but
no, I was just curious, Rachel. Thanks ever so much. It's about education as well, isn't it? It's about getting the message out there, which is yeah. Okay, thanks, Rachel. Thank you. Thanks, John.
Excellent. Yvonne, now we've got one from Sarah. Now remember, Rachel, she'll be quoting you, and it'll be the references at the bottom of her master's dissertation.
Hi, Sarah.
Rachel,
We
sorry.
work together. It's nice to see. Well, actually, I can't see you. I can just see your hand, your virtual hand. But
Oh, can you? Is
There's
that better?
there you
That's
are.
good, yeah.
Sorry, I've probably got quite a few questions because I suppose will you continue to follow these patients up to see what happens longer term?
So I haven't, because now I've left the trust, which
Yeah.
I'm terribly sad about. But I think it would be a really good project for the incoming. It's Danielle Rayner, who's replaced me. Because it would be a really interesting project to see what happens 12 months, 18 months down the line. Yeah, I can't access
No, I know that's sad, isn't it?
Yeah, I'd be quite grateful if Danielle would carry it on, really, just for to see what the journey is for those patients.
Yeah, because then, would you do it again with a new set of patients? And then because you brought up about the mental health, would you maybe include that in the Fibroscan if you were to repeat it?
In an ideal world, yes.
Yeah.
But I'm not sure who would be, I'm not sure who would be best placed to provide that. You really need a separate mental health component, I think, or somebody who is there to do, the mental health component of addiction and dependency.
Sorry, I don't want to overtake the meeting. It's just that. So my master's is going to be on motivational interviewing with patients who attend clinic, and maybe, we're looking at a 12-week course of weekly sort of motivational interviews just to get around that mental health aspect of it. So, and I know that there's nurses trained in the hospital. So actually, if we, because at the moment it's just for inpatients. But if we
are they
so like Lorraine,
I mean, perfect. Lorraine would be brilliant.
She would
at that exact role.
And the fact that they Fibroscan as well.
Yeah, but it's getting enough of those people, isn't it?
Yeah. So actually, it's quite interesting. So when I did mine with Lorraine, there were 13 of us in the class, and that includes the sister on one of the wards in A&E. So there was some of the HCC nurses. So yeah, there was quite a good mix of people there. So there are people about, but I think it's just timing, isn't it, and use of resources when everyone's so short.
And it's the follow-up as well, the long-term follow-up of the support with, staying sober and all of that as well, and who's best placed to provide that. Is that us in a hospital setting, or is that somebody in the community?
Absolutely. Absolutely. But it's just, if people are coming to hospital, and especially like you say, the lack of knowledge, lack of awareness,
Mm.
and like the community addiction centres, it's quite a big step, isn't it? If you don't realise that you're drinking too much
Mm.
and
So,
you're in denial because of the stigma around it.
yeah, totally. One of the things, I'm sort of pinching the idea, but one of the things that I'm hoping to do at my current trust, which is actually an East London based hospital, is looking at the Fibroscan outcomes from all the patients who are plugged into the drug and alcohol. It's called Turning Point, the drug and alcohol centre that's like close to the hospital. So I just want to see what happens in a similar group, different part of the country, but so I will be doing the same project again, actually, but with a slightly different population.
That's interesting.
Yeah, it will be interesting to see. I've just got the data just yesterday, so going to start plugging through that. But it'd be interesting to compare and contrast, really.
Absolutely, yeah. Because I suppose in the Northeast, we always think like we're really quite deprived, and obviously that affects people's choice of lifestyle habits, doesn't it?
Yeah. So actually, because I was talking about this work to my new colleagues in this London Trust, and the indices of deprivation data are actually quite similar for the specific East London that I'm working in.
Right, okay.
With that of the Northeast,
Yeah.
which I was quite surprised by, but so there are similarities. Be interesting to see.
I know it will. It will. You'll have to feedback.
I will do so.
Oh, thanks, Rachel. Thank you.
Oh, you all right with that then, Sarah?
Yes, that's great. Thanks,
Jolly
John.
good. Yvonne's back. You're muted, Yvonne still.
Yeah, sorry, John.
Sorry.
Just on the back of that, really, is there any sort of mileage in working with people? When you're talking about obviously alcohol dependency and mental health, is there any, Alcoholics Anonymous, the people who support these groups are actually really experienced, I would say, in sort of like the motivational work and the I think, is it the 13 steps or whatever steps, and I don't know that much about it, to be fair, but I do know people who've actually been part of that, and they're quite severe when they they don't sort of, pardon the French, I'm not suggesting anybody else does pussyfoot round it, but the thing about it is that always strikes me is that, well, you've actually got a choice, and I just wondered if they had any advice or expertise that they could help working together with the health service. I'm sure they probably do, but I just wondered whether you'd sort of looked into that as a possibility, Rachel. I don't know.
Yeah, it's not something I have looked into, and actually, I don't know if we certainly in Newcastle we certainly had relationships through the alcohol specialist nurses, Lorraine, who I mentioned. We certainly had links with the Newcastle Treatment and Recovery Centre. The brand of sort of AA as such, I don't know. I don't know that we have links with them in healthcare, or how their style differs from Newcastle Treatment and Recovery.
Yeah,
So,
it would be good to know, because it's like smoking. You can explain to people how badly they can be affected in the long term, but that doesn't necessarily affect their behaviors there and then. Do you know what I mean? I just wonder that there's no magic drug, is there, really? If people's motivation, you can't sort of stimulate people's motivation to do something that's going to benefit them.
No, but one thing that I think is quite crucial is that everybody knows the same. So people know that, because I think some of the problem is that people don't know often that their behavior is harmful. So it might seem blindingly obvious that if you sink 100 units a week of alcohol, that's harmful in the long term or sometimes the short term. But actually, that is not necessarily the norm, and people don't necessarily know that because education on the matter is limited and because society is driven in the opposite direction, really. Every which way you look, we're being encouraged to buy alcohol through advertising. And so I think as long as people are making a conscious decision to continue their harmful behavior, then, you know, people have that choice to make, but they must be provided with the information to do so. And that for me is where I think public health campaigns have fallen short of the mark. In a big way for liver disease in general, but specifically to do with alcohol.
Yeah, I would agree. Awesome.
Sarah?
Sorry, can I jump in as well? Because we have seen autoimmune liver patients who think they were actually doing their liver like better by drinking a bottle of red wine a night because they'd heard red wine was good for the health.
Right, that's
and then
I've not heard that
I
before.
played a game with, I had a study day with some of the HPB nurses, and we had a game about, you know, non-alcohol, which drink has the most units in, and people were saying that the non-alcoholic cider had more units in than actual alcoholic drinks. So where Rachel says about even healthcare professionals not having the knowledge, like that is certainly what I found.
Yeah, totally. And often it's not uncommon that people will come to clinic and a liver clinic for whatever reason, and it's the first time anyone has ever really delved into exactly what it is they're drinking, and then you tally up those units in front of them or in front of a patient on the computer or whatever, and it comes as a real shock to people. I've played similar sort of games with my own friends, you know, and you tally up the units and everyone's sort of a bit taken aback, you know, because it's not immediately obvious how many units are in whatever drink.
It's not, no.
We in our leaflet on liver disease on the number 5, that one we've been talking about, we refer people to alcoholchange.org. I don't know if you've heard of it. It's a company, and they will tell you how many units are in each type of drink and which items are safe. And there's a lot of non-alcoholic drinks coming out now that are exactly the same flavour. Not that it helps. And we do have a man in our helpline who's been an alcoholic. He's had cirrhosis and he's totally reversed it all. And he's a great he's a great advocate for and he actually said it isn't all that wonderful for everyone. It works for some and not for others, you know. So that's something that we don't want to force people to do it. They have to choose to do it, haven't they? Otherwise, they'll be against everything you advise them.
Yeah, and I do find that there's a stigma, not just on alcohol intake and having that label of drinking excessive alcohol, but AA itself, where they think they're going to sit round in a group and they have to sit there and say, I'm an alcoholic in front of a whole load of strangers, and they find that off-putting because I did an audit of inpatients and there were lots that had refused to go to AA just for that reason.
Yeah, that's right. There are other organisations, you know, but this Alcohol Change is a good one to refer people to. I thought this was going to be a disaster tonight because we didn't have many people coming. It's half term, and disaster doubled because it's Newcastle playing at home tonight.
Oh, right.
So, we've actually got about 15 people watching, which is unbelievable.
I should really have known that. I tried to make myself a token. I don't really follow football, but I did try to follow some football during my time at Newcastle.
So that's you've done very well, Rachel, attracting as many people as you did. So that's good. Well, thank you very much. We'll if everyone's happy, we'll end the recording, and we have another meeting in November, and it's David Jones. So he'll be on fine form. So sleep well, everyone. I hope there's not too many fireworks tonight. My dog's been going crazy. Okay, and I'll close the meeting.